Hey everyone, welcome back to our latest explainer. I've got to tell you, I am genuinely so hopeful as I guide you through today's topic because the medical landscape is literally shifting under our feet right now, and it is happening in the best way possible. Today, we're unpacking the absolute latest 2026 updates to non-small cell lung cancer treatments. Look, if you or a loved one are navigating this diagnosis, I know the sheer volume of new information out there can feel completely overwhelming, but, well, that's exactly why we're here. We are going to break down these new clinical guidelines, understand the newest therapies, and look at exactly how oncologists are completely rewriting their battle plans. Okay, let's dive right into this. For decades, a lung cancer diagnosis carried a pretty grim set of expectations, right? The old reality meant the medical goal was almost strictly defensive, mostly just about prolonging life. But today, the ultimate goal of the modern medical arsenal has totally shifted. Thanks to some truly breathtaking advancements in precision medicine, oncologists are now aggressively aiming for a complete cure, or what they call a complete remission. Yes, even in advanced stages. It's a fundamental, absolute game changer in how we approach this disease. So to make sense of all these breakthroughs, here is our quick roadmap for today. We'll start with the dramatic evolution of treatment, then look at the new weapons targeting cancer, cover the pincer strategy, discuss crucial genetic testing, and finally talk about choosing the best treatment. All right, kicking things off with Section 1, the dramatic evolution of treatment. To truly appreciate where oncology is at in 2026, it really helps to use a military metaphor to understand how radically our tactics have upgraded. Think about classic chemotherapy. Honestly, it was essentially carpet bombing. It attacked fast-growing cells, sure, but it damaged a ton of healthy, normal cells in the process, leaving behind this scorched earth of heavy side effects. Then came targeted therapy. Now, this was a massive leap forward. It acts way more like a precision sniper, actively seeking out and hitting only specific genetic mutations on the cancer cells. But now, we've evolved even further to ADCs, or antibody-drug conjugates. These act as precision cluster bombs. They give us the pinpoint accuracy of a sniper, but with an expanded blast radius that takes out the enemy even when it tries to hide. Moving right along to Section 2, the new weapons targeting cancer. Remember those precision cluster bombs we were just talking about? Those are antibody-drug conjugates, or ADCs. Drugs like Enhertu are a textbook example. Here's how they work, and it's so cool. The antibody basically acts like a Trojan horse. It specifically locks onto a protein on the surface of the cancer cell. Once it's pulled inside the cell, boom, it detonates, releasing a highly potent dose of chemotherapy directly into the tumor. But here is the sheer genius of an ADC. It creates what's known as a bystander effect. Once that initial cancer cell is destroyed, the chemo actually leaks out and destroys the neighboring cancer cells, even if those cells are trying to hide without that targeted protein. It's an incredibly smart way to overcome the limitations of older targeted therapies. Another critical weapon in the 2026 arsenal is immunotherapy, or immune checkpoint inhibitors. You might know these by names like Opdivo or Imfinzi. You know, cancer is incredibly sneaky. It actually puts the brakes on your body's natural immune system, essentially throwing an invisibility cloak over itself so your white blood cells just walk right past it. Immunotherapy strips away that invisibility cloak. It releases the brakes, unmasks the tumor, and signals your body's own natural defenses to rush in and join the fight. Suddenly, your immune system recognizes the cancer for what it is and attacks it directly.
Next up, Section 3, the pincer strategy around surgery.
So, the crucial point here is how this perioperative timeline actually works. Perioperative just means the time around the surgery itself. Instead of just going in for surgery and, well, hoping for the best, oncologists now use a coordinated pincer attack. Step 1, before the surgeon even makes an incision, patients are given powerful drugs to shrink the visible tumor and hunt down invisible micrometastases that might be circulating in the blood. Step 2 is the actual surgery to physically remove the localized cancer. And Step 3 is post-surgery adjuvant therapy. That's where we follow up with more drugs to mop up any lingering microscopic threats. By attacking the cancer from both sides of the surgical timeline like this, the recurrence rates drop drastically. And when we talk about preventing that recurrence, I really want you to let this stunning number sink in. 84%. According to the latest data we're looking at, using the targeted drug Tagrisso as a maintenance therapy after radiation for stage 3 cancer extended the time until recurrence for 84% of patients. That is an absolutely massive improvement. It's doing an incredible job keeping the cancer at bay and giving patients their lives back. All right, move into Section 4, crucial genetic testing. You simply cannot pick the right weapon without gathering intelligence on your enemy. When we map out the distribution of driver mutations in Japanese non-small cell lung cancer patients, a massive 50% have an EGFR mutation. Now, think of a driver mutation like a broken engine switch that's forcing the cancer cell to just constantly multiply. This is exactly why you hear about EGFR-targeted therapies like Tagrisso so frequently. It directly applies to roughly half of the patient population in this demographic. Then you see 15% of CRAS, 5% of ALK, and so on. The big takeaway here? Lung cancer isn't just one single disease anymore. It is actually a collection of rare micro-diseases defined by these specific genetics. Because nailing down that exact mutation is so critical, the patient journey requires a very specific intelligence-gathering phase. Step 1 is collecting a tissue biopsy or a blood sample. Step 2 is honestly the hardest part, waiting 1 to 2 weeks for the genomic profiling results to come back. I know that waiting period feels absolutely agonizing when you just want to start fighting back, but step 3 shows exactly why it's necessary. It allows the oncologist to perfectly match the specific driver mutation with the optimal custom-fit targeted therapy. Waiting for this intel is the absolute prerequisite to winning the battle.
Now, what's really interesting here is how the choices are expanding even within one single mutation category. For patients with that common EGFR mutation, the 2026 guidelines lay out 2 distinct pathways. One path is the combination of Lazicluze and Rybrevant. This is currently the most powerful aggressive guideline treatment out there. However, it does require both IV infusions and oral pills, and it does come with a higher rate of side effects like blood clots or skin issues. On the other path, we have the standard Tagrisso monotherapy. It is still highly effective, but it's much gentler. It's an oral pill only, has fewer side effects, and is highly recommended for patients whose physical strength might be a bit lower. There is no single right answer here, guys. It's all about matching the treatment intensity to the patient's reality.
And for those who don't have the EGFR mutation, the 2026 specialized breakthroughs are equally astounding. The sheer variety of targets we can hit now is basically a barrage of medical victories. We now have Lumacross, specifically designed for the incredibly stubborn KRAS G12C mutation, a target scientists literally couldn't hit for 40 years. There's Zungrininib for HER2 mutations and Repotretinib for ROS1 fusion genes. For relapsed small cell lung cancer, there's a bispecific antibody called tarlatamab. And if a cancer builds resistance to a drug, new therapies like amivantamab are being deployed to bypass that resistance. Even incredibly rare, previously undruggable mutations now have dedicated countermeasures. It is amazing. Which brings us to our final section, number 5, choosing the best treatment for you. Because at the end of the day, the absolute most high-tech weapon isn't always the right choice for every individual soldier on the battlefield. Cancer treatment does not happen in a vacuum, right? It happens right in the middle of your actual life. It is vital that patients actively communicate their lifestyle needs to their oncologist. What is your personal tolerance for side effects like severe rashes or diarrhea? How often can you realistically visit the hospital? Do you strongly prefer a daily oral pill over regular, time-consuming IV drips? How will the treatment schedule balance with your job, your family, or your household chores? Balancing medical efficacy with your daily quality of life isn't just about comfort. Studies actually show that patients who can sustainably manage their treatment and side effects experience better long-term survival. We have covered a tremendous amount of ground today, from the shift toward aiming for a cure to those cluster bomb ADCs, surgical pincer strategies, and vital genetic intelligence gathering. But as you step into your next medical consultation, I want to leave you with this single empowering question to chew on. Which treatment method best fits your life right now? The tools to fight lung cancer have never been more advanced or more personalized. You are an active partner in this journey, so take this knowledge, ask the hard questions, and choose the path that makes the absolute most sense for you. Thanks for joining me on this explainer, and keep learning.